Thank you very much, Professor Tao, for this kind introduction. I would also like to thank Merck for having me. I hope this microphone is working. Yes. So again, thank you for having me. It's a pleasure to be in Vietnam. I've been here before. It's the second time, but unfortunately, I didn't have time to visit your beautiful country. It's always hotel, airport that I'm seeing. I hope next time I can bring my family so see more of your beautiful country. Now, the topic which I was asked to speak about is a very interesting topic and I think very challenging topic, because today, especially 2022, 2023, we are reaching the era of individualized medicine. It is, as it was mentioned previously, the time of individualization. And in fact, when you stimulate a patient, you create a completely abnormal environment. Now, for the current presentation, I have no conflict of interest. Now, if you take a look at reproduction or female, it's a very inefficient system. You might say inefficient. It's 8 billion of us out there, and still it's an inefficient system. The answer is yes, it's actually a very inefficient system. Why is that? You see a baby girl who is around 24, 25 weeks of age. She has around 7 million small, let's call them eggs, oocytes, or germ cells present. You might say 7 million is a huge number. Who is needing 7 million children? Now the thing is, from 7 million, the moment you are born, you go to 1 million. You might say, okay, 1 million is still more than enough. The thing is, when the baby girl is born, she is not ovulating. So she's going to ovulate at the age of 12, 13, 14. At that time, she goes from 1 million to approximately 300,000-400,000. Now, you might again say 300,000-400,000 more than what mic is not working properly. Sorry. Thank you. I hope you can hear me better now. Yes, I can hear myself better, so perfect. So 300,000, 400,000, it's a good number. The problem is from these 400,000, in your whole life, you're going to use only 400 to 500. And the bigger problem is from these 400 to 500, more than half of them, depending on your age, will be genetically abnormal. So I think you agree it's a very inefficient system. Now, obviously, age is one of the best predictors for getting pregnant. But is it really a good predictor to evaluate the ovarian reserve of a patient? The answer is clearly no. As you can see, at any given age, you can be a high responder or you can be a poor responder. Even if you are older, you still can have a good ovarian reserve, or you can have a very, very low ovarian reserve. So age is not the only predictor of the ovarian reserve. It's also genetic predisposition, environmental factors, and many other factors which are still unknown to us. So every woman at any given age can be a normal responder, high responder, or a poor responder. Obviously, the older women get, the more poor responders you will have. That's logic, but that can be present at any given age. Now, the $1 million question, how many eggs do you need? You would say maybe 10, maybe 12, maybe 14, because this is what has been published. But do we really believe in a certain number? The first question I would ask myself, how many eggs for whom? 14, 15 eggs for a 45-year-old? Or 14, 15 eggs for a 25-year-old? I think all these questions need to be answered correctly. The second question I would ask myself, how was the stimulation done? Does it matter how you stimulate? Of course it matters. As it was previously mentioned by Professor Tao, it's a new field of medicine. A lot of questions still have to be answered. And are we there yet? No, we are not there yet. But every day we are gaining more and more knowledge. So here, as you see, people have published the best number is somewhere around, let's say, 14, 15, 12, 13. And if you have too much at that time, and this is an old publication by a good friend of mine, Biljana Popovic, there was cancellation because of hyperstimulation. Obviously, today, I can tell you the last hyperstimulation I have personally seen was 6 years ago. The last hyperstimulation I have seen was 6 years ago, because we don't see that anymore with all the tools that we have in our hands. Now, others have published big data sets, and they confirmed, yes, actually the best number is around 15. After 15, you seem to have a drop. But why is that? Why should you have a drop after 15 eggs? Why exactly 15 eggs? And by the way, this is nothing novel. These had already been published before. Van der Gaas from Netherlands published the same. You see 15 eggs, from 15 you have a drop. But again, why 15? What's happening at 15? Are the eggs overcooking at 15, or is something else happening at 15? Or is it related to the way we are stimulating the patients? Because that might also be a factor. We should not neglect what is happening when we administer hormones to those patients. We change the endocrine environment. We create a completely abnormal endocrine profile. And that can sometimes have a negative impact. And this could be one of the negative impacts if we are not stimulating correctly. And I'm going to come back to that point. Now, because we have published in Human Reproduction a few years ago that the more eggs you have, the better is your pregnancy rate. So why do we not see this magic number 15? And magic number 15, you have to ask another question. As I mentioned, what patient? And this is a beautiful publication a few years ago in Fertility Sterility from the US. So what they published here, because patients ask us, how many eggs do I need to get pregnant? So you have to tell them, look, it depends. Are you 30? Do you want to have 1 child, 2 children, or 3 children? Or are you 35? Or are you 38? Or are you 41 or 42? Because imagine you are 30 years of age, and you have, let's say, 15 eggs. With 15 eggs, your chance of having a baby is 80%. But on the other side, let's say you have 15 eggs and you're 41, your chance is maybe 20, 25%. So 15 is not equal 15. There is a difference. For whom? And how was the stimulation conducted? I think that's a more important question. Why 15 not equal 15? Because obviously you have more aneuploidy the older you get. So the older women get, the more aneuploid oocytes you have. And you might argue, what about the sperm and so on? That's a different entity, but sperm does not create aneuploidy. So this is really mitotic origin of the oocyte. The old Romans used to say, life comes from an egg, and that's the truth. Life comes from an egg. Now, when we stimulate a patient, obviously we have multiple things that we are looking at. We have to look for efficacy, safety, cost, and patient accessibility when we stimulate those patients. You have seen patients are different. So when patients are different, we need to understand how we evaluate this difference. How can we objectively evaluate the ovarian reserve of those patients? Obviously, you can use the ultrasound, antral follicle count, or the so-called egg timer anti-Mullerian hormone. Now, what is the primary task of AMH? Because this is also important. We measure AMH for ovarian reserve, but physiology didn't design AMH to be measured for ovarian reserve. It has a certain task. What does it do? In fact, AMH is responsible to prevent primordial follicles to be recruited and to become responsive to gonadotropins. That is what AMH is doing. So AMH is produced by small follicles, pre-antral follicles, and the task is to create a negative feedback to stop primordial follicles to be recruited to become receptive to gonadotropins. That is what AMH is doing. Now, we use that as a marker, but we need to be extremely critical of using that as a marker. And I will elaborate to you more why. So we know AMH is produced, the maximal expression is by pre-antral and antral follicles. And basically, the bigger the follicles become, the less AMH they produce. On the other side, if you take a look at the scan, with the high-resolution scans that we have today, you see the visualization is extremely beautiful. So you can visualize all the follicles, and you can see exactly what you're dealing with. I always say, what you see is what you get. And that's an important statement. And I will tell you why. So these are the images that we usually see with the scan. And you don't need to do a 3D scan. You can also do that with a good high-resolution 2D scan. Now, Bart Fauser and others published many papers looking into various factors, how to anticipate age, FSH, antral follicle count, AMH, and they all seem to be somehow reliable. But let's be a little bit more critical. So we said AMH is being produced by small pre-antral and small antral follicles. But if I would ask you, what follicles are producing the biggest amount of AMH? What would you reply? What if I told you more than 60% of AMH is produced by follicles of 7 to 8 millimeters? It means 60 to 70% of AMH that you measure is from the follicles that you see, the bigger follicles that you see, 6, 7, 8 millimeters. Now, we know that there is something, it's called intercycle variation. It means a patient between the cycles can have significant different antral follicle counts. So if you have different antral follicle counts, you will also have significant differences in your AMH production. Obviously, because most of that AMH is produced by bigger size follicles, 6, 7, 8 millimeters, as you can clearly see here. And obviously, the bigger those follicles become, the less AMH they produce. Logic. And once they go above 9, 10 millimeters, they stop producing AMH. Now, it's extremely important to realize the intercycle variation. It means the same patient, within 2-3 months between, undergoing different stimulations, she will have a significant different response. Why? With the same amount of stimulation, because of intercycle variation. Same patient. So if you have physiologically different antral follicle count between different cycles, obviously your AMH will also differ significantly. Furthermore, not only FSH has different isoforms, also AMH has different isoforms. And if you take a look at the different isoforms of AMH, as you can see here, pre-pro, pro-AMH, and NC, it contains 2 parts. And basically, all these fully automated assays that you are today using in your labs, they have antibodies capturing certain parts of that molecule. This is how you measure AMH. Now, that has also some technical issues because there are analytical issues. There is variation the way you measure it. And these variations has been published on many occasions. There are significant differences the way you measure, even if you use fully automated assays. So you already have technical variation.
with AMH. But what about biological variation? Simple biological variation, as you have seen, like you have antral follicle count variation. Now, this is a paper we have published a few years ago on the right side, and a similar paper was published also confirming the same. AMH does have significant biological variation. You might ask, what does it mean, significant biological variation? It means you have 20% intracycle variation. It means within the same cycle, you have 20% variation within the same cycle, and you have 28% intercycle variation between two cycles. So you have 20% within the cycle, 28% between the cycles. And of course, you also have the technical variation that you have seen there. The problem is this is not stopping here. It gets worse than that. So when you are having your sample, do you think every lab is running the test immediately? No, they don't. They do not run the samples immediately. Sometimes they keep them until they have enough samples to run them at once. So what do? Sometimes you freeze the sample. But how do you freeze the sample? -20, -80, how do you do that? And there is another variation that you have, up to 230% variation. So you have technical variation, assay variation, and biological variation. So as you can see, we have really a lot of variations when it comes to AMH. This is a paper, we just published it 2 weeks ago. It just came out 2 weeks ago. It's so-called Delphi consensus. So we were a part of that group which came out with that paper, where we made a statement, be cautious on AMH. Antral follicle count is much more reliable than AMH. And this is where we have to put our clinical judgment on, because this is what you see. What you see is what you get. Now, I'm going to share with you just a clinical case. This is a patient I saw 3-4 months ago, very recently. And we are in the process of publishing that case report, because it's an important case report. She was referred to me because she was in the menopause. So she was 33 years old, and she had 4 children, but she was in shock because she said, I'm in menopause. She saw 3 different doctors. Those doctors, they did an AMH with her, and her AMH was 0.08. It was measured again. It was 0.01. It was measured again. It was 0.02. So I told her, I'm sorry, you're in the menopause. There is nothing we can do. So she was referred to us. Now, we did a scan, and she had the typical PCO aspect, polycystic ovarian aspect. I might say, what's going on? AMH is 0.0 with various assays, but she has an antral follicle count of PCO. Now, imagine if you would put your clinical judgment on AMH, what would happen to that patient? She would have died because she would be exploding. She's a high-risk PCO patient. Now, what was the problem with that patient? We did a scan, and you see here is an endocrine profile, typical PCO, LH23, FSH7. Why does she have a PCO aspect? Because she has no AMH. The no AMH inhibits the recruitment of primordial follicles. So this inhibition is gone. So she is recruiting every follicle. This is why she's having a PCO aspect. But why is this happening? Because that patient is having a defect in one of the amino acids. And what we did we sent a sample to a lab with which we collaborate in Texas, US. They run several tests, different assays. All of them came out as 0, but the inhibin B production was correct. It means those granulosa cells were producing enough inhibin B, but somehow the AMH, with all the antibodies that we have in different assays, was not measured. And actually, the problem was, again, one amino acid that this patient didn't have. So with the whole exome sequencing, what came out, that the amino acid valine was replaced with melatonin in codon 87. So just one simple amino acid change, and none of these machines is able to capture that. That's if you rely simply on a biological marker. And this is the stimulation. As you can see, she had a beautiful stimulation, and a lot of eggs and embryos after genetic testing were frozen. Now, if you put all these findings on one page. AMH, as you have seen, it has significant analytical variabilities, depending on assay sample storage, but also biological variation. There is no standardization across assays, pre-analytical instability, AMH isoforms, as you have seen, and significant inter- and intracycle variation. On the other side, antral follicle count, very easy to perform. It's non-invasive. You have immediately the result. And as I said, it's dynamic because you see the patient now and you have it in front of you. What you see is what you get. Now, let's say you have done the evaluation and you know how to stimulate the patient because you have done your measurement and you know how many follicles this patient has. You know the age of the patient. You know the body mass index of the patient. And I'm not saying body weight. I'm saying body mass index of that patient. And I will come back to that. Now, when you stimulate the patient, obviously, you change the endocrine profile of that patient. You change the complete environment. Normally, the patient has a monofollicular growth. She has one follicle. When we stimulate, we have maybe 8, 10, 15 follicles. So we all agree that we are creating a different environment. You might say, yes, we know that. Why are you telling us this? Very simple. Very simple. The uterus and the endometrium of a woman is the worst place for an embryo to be in. I'm going to repeat myself. The endometrium of a woman is the worst place for an embryo to be in, except 2 days in a month. In a cycle of 28 days, the endometrium is receptive for approximately 48 hours. And these 48 hours is planned according to the time of progesterone exposure. And this is what you see in this slide. This is a beautiful paper published in Nature Medicine, 2020, so 2.5 years ago. So you see in the proliferative phase, these genes are upregulated. Then you have late proliferative, some genes are slightly downregulated. You ovulate, you are early secretion. But then after approximately 120 hours, what you see is a sudden downregulation. You have a sudden downregulation of the genes. And this is your window of implantation. And then you have, again, downregulation. And this is the time where the endometrium is receptive. That's extremely important. Because when we stimulate a patient, we are playing with this part. We are playing with the window of implantation. And this is determined by the hours of progesterone exposure. Why progesterone exposure? Because the moment we stimulate patients, and if you don't do that correctly, we might interfere with the window of implantation. Now, these are beautiful publications from my university. It's, in the meanwhile, I think 20 years ago, where it was published that the endometrium of all women who are being stimulated are advanced. That means the moment you take an injection for ovarian stimulation, you create an abnormal environment. You create an abnormal environment the moment you stimulate a patient. Now, this abnormal environment creates endometrial advancement. It means the endometrium of that patient is advanced. So your window of implantation is advanced. And if the window of implantation is advanced too much, the implantation of the embryo reduces significantly. Now, if I would ask you the question, why do you think is the endometrium advanced with all women who are being stimulated? Now, the first answer you will tell me, because we stimulate them and we have high estradiol values. I would say no. Because estradiol does not create secretory transformation. What does create secretory transformation is the progesterone. So the moment you stimulate, indeed, you create high levels of estradiol. Good. Estradiol itself creates progesterone receptors. Good. But as long as you don't have progesterone, you have no secretory transformation. But where does the progesterone come from? And that is exactly what we described in this paper. So this is a paper we published a few months ago. You see, imagine you have a patient today and she's ready for the triggering, for the final oocyte maturation. Her progesterone is low, 0.7, 0.8, is normal. You trigger her today at 8 p.m. Do you know what is her progesterone at 10 p.m.? Double. It means when you have a low progesterone, 2 hours after the triggering, you double the value. And this is exactly what we published in this paper. So you see, within 2 hours, you have a doubling of your progesterone value. And this is why you have advanced endometrium with all patients who are being stimulated. Because of a triggering, you have an accelerated rise of progesterone. Now you could say, what happens in nature? This is what is happening in nature. This is a paper we published very recently. I think 2 weeks ago the paper came out, where we described the natural cycle, how to do a natural cycle correctly. Now what happens in a natural cycle? In a natural cycle, your progesterone doesn't go up like this. What you have first is your LH rise. Estradiol is still high, progesterone down. The second day, LH up, estradiol down, progesterone still down. It's 2 days after your LH rise that you have an initiation of progesterone rise. But in a stimulated cycle, because of your triggering, you have an immediate rise of progesterone. So endometrium is already advanced, okay? Now you are asking yourself, why do you talk about the endometrium? And I will come back to that point, why it is so important. So you have, with all women who are being stimulated, more hours of progesterone exposure. So all women who are being stimulated, their endometria are exposed to progesterone on day 5, not 120 hours, but 150 hours. It means you have narrowed your window of implantation. So if you put that in a graph, and this is a paper we published in Human Reproduction, I think 2 years ago, you see, normally in a natural cycle, you have your LH rise. After 2 days, you have your progesterone rise, ovulation, blastulation, and after 120 hours, you have opening of your window of implantation, which is around 2.5 days, and then you have a closure. This is what's happening in a natural cycle. But look what's happening in a stimulated cycle. Even if you do not have premature progesterone rise, you do not have a rise of progesterone before the triggering. You see, you trigger, and immediately after your trigger, you have a rise of progesterone. Immediately, as you have seen, 2 hours after your triggering. It means the moment you have your blastulation, your endometrium is exposed to progesterone 150 hours. So your window of implantation, as you can see here, is narrow, very narrow. You might say, yeah, but still there are patients getting pregnant in a fresh cycle. Of course they do. Why do they become pregnant? Because if the embryo is developing fast and it's a big embryo, it will implant. But if the embryo is developing slow and you have very advanced endometrium, the pregnancy rates are significantly lower. So if you control perfectly for progesterone, you have a narrowed window of implantation, and a good embryo will implant anywhere because this narrow is enough. But all the other embryos will fail to implant. But what would happen if you stimulate and you have elevated progesterone? Even that good embryo would fail to implant because you bypass the so-called window of implantation. And that has been published on many occasions. You see Ernesto Bosch paper, if progesterone goes up, pregnancy rates drop. Now you might say, yeah, but if progesterone goes up, I don't care. I'm going to freeze. I'm going to put back in a subsequent cycle. But what if I would tell you that this also has an impact on the oocyte and embryo quality? We know that if you have high progesterone during follicular phase, while you are stimulating, you might also jeopardize not only your endometrium. If you give too much of FSH, for example, especially towards the end of the follicular phase, what will happen? The pregnancy rates go down, and also the oocyte and embryo quality also decreases. Now we know the bigger the follicle becomes, the more progesterone it produces. And some people, especially pharma-sponsored studies, came out with the idea, yeah, it's a lack of LH activity, it's a lack of ACG, and so on. So this is why we need to add ACG or LH towards the end of the follicular phase to prevent this from happening. But what they didn't see at that time, and this is a paper, it's an old paper by now, you see they compared HMG with REC-FSH, and they said, look, with HMG you have less progesterone. But I think they did not know this paper, which was published in GCM a few years before that. The bigger the follicles become, the more progesterone they produce. So here, they triggered this group of patients on a significantly bigger size follicles. Of course, the bigger the follicle becomes, the more progesterone it produces. And in fact, the same group tried to add ACG to show that they were right, and obviously they were wrong. Because as you can see, the more ACG you add, the higher is your progesterone. In fact, ACG or LH activity is the main contributor to progesterone rise. It's not preventing progesterone rise. As you can see in this slide, the more LH you have, the higher is your progesterone level. The more LH receptors you have, the higher is your progesterone. So this is not preventing premature progesterone rise. But if I would ask you, why does progesterone go up with some patients during ovarian stimulation? That's an important question. So we looked into that. This is a paper we published with Dimitra Kirou in the meanwhile also 10, 12 years ago, where we realized this is somehow linked to the FSH. The more FSH we give, especially towards the end of the follicular phase, the higher is the risk of having progesterone. Then we started understanding if you give FSH, you create more LH receptors. And LH receptors are responsible for progesterone production. So maybe it's because we are not stimulating correctly. Maybe we are giving unnecessarily too much FSH on a specific time period of stimulation. And this theory was also confirmed by a paper published by Octem in Human Reproduction, that yes, too much FSH is the cause of premature progesterone rise. Now, if you look at ovarian stimulation, obviously we are using FSH, we use LH, sometimes we add ACG. All those molecules are very similar. In fact, if you take a look at LH, FSH, ACG, as you can see, they have two parts, the alpha part and the beta part. And as you can see, the alpha part is exactly the same. The difference that you see is in the beta part. And in fact, for example, ACG has 21 amino acids at the end, the so-called carboxy terminal peptide, and this is giving a very long half-life time of ACG. But as you can see, they are very similar. Now, if you take a look at the stimulation and you compare it with a natural cycle, you see the way nature works is it selects the follicle, and the moment the follicle is selected, FSH goes down. But this is not what we do in a stimulated cycle. We constantly stimulate those patients. And I will come back to that point shortly. If you take a look at the molecule of FSH, this is an FSH molecule. As you can see, it has 4 arms, 1, 2, 3, 4. Each one of these arms can attach up to 4 sugar residues. What do these sugar residues do? The more sugar residues you have, it's called glucosylation, the higher is the acidity of that molecule. Now, what does this acidity do? Obviously, the more sugar residues, the more acidity, it increases the biopotency and the half-life time of the FSH molecule. So as you can see, the highest acidity has the longest half-life time. So FSH, 4 arms, each arm can have 4 sugar residues, and the more sugar residues you have, the higher acidity, the longer is the half-life time. Now, you could ask the question, what happens in nature? You see, in nature, you start with an acidic isoform, and then you go towards the end of follicular phase to a more basic isoform. And if you would look at the time, in the start of fertility, it's less acidic. Women go to menopause, it becomes more acidic. So during the cycle, it differs. Between the phases of life, it also significantly differs. Of course, obviously, men do have FSH isoforms. Now, we know that recombinant FSH is relatively basic. Urinary is more acidic. And in fact, the highest acidity is something which is called choline alpha, which has a part of ACG, which has the longest half-life time. Now, you see, very often people are comparing, let's say, rec FSH with HMG. That's what many people do. And they draw conclusions. But what they don't understand, when you are comparing these two drugs with each other, even if you would use the same dose, which usually is not done, how many variables do you have here? You have two variables. One variable is recombinant FSH versus urinary. As you see, there is a significant difference. The other variable is ACG or LH versus no ACG, no LH. But if you have two variables, it's very difficult to draw conclusions because this outcome would be based on what? Now, when you use recombinant FSH, you can tailor the treatment according, for example, to antral follicle count of the patient. If you have, for example, a patient with a high antral follicle count, you start with a low dose. If you have a patient with a normal response, let's say 7 follicles on each side, you start approximately at the higher dose, and a poor responder, you can go up to 300. Now, the ESHRE 300, we had a debate last year at ESHRE about this topic, because 300 might have a different response among different women. So there have been systems to anticipate and predict the response of the patients. And we know that if you individualize versus non-individualized treatment, that with the individualized treatment, you harvest what you are looking for. It's much more objective and much clinically more justified to individualize the treatment than not to individualize the treatment according to the patient's requirement. But we have to look back to nature to have a better understanding on what we are doing. You might say, but in nature you have a monofollicular growth. You have only one follicle. I fully agree. But you could mimic the same on the higher level. So you see what is happening in nature. Your follicle is being recruited, but the moment the follicle is recruited, the FSH goes down. Why is this happening? Why does the FSH go down? And why does this follicle not go into regression? Because you would think this follicle is maybe 13, 14 millimeters, and the FSH is going down. You would think that that follicle would go to regression. But it's not. Why? Why does that follicle not go to in regression? And if you take a look at the way we stimulate women today, you see, you stimulate until you bypass a certain threshold, but you continue stimulating, right? And a correct way of stimulation would be you start stimulating, you recruit the follicles, you bypass the threshold to have multifollicular recruitment, but once this is done, you should go down towards the end. So this is the way we do, and this is the way we should do. Start at a certain dose, recruit those follicles, and then adjust the dose to the patient's requirement. But you might say, but if you do that, all the eggs will become smaller and they will disappear. I will tell you no. Why? Very simple. You see, a follicle in the beginning of the follicular phase, it has approximately 90% FSH receptors. So you have 90% FSH receptors of a small follicle. This is the time you start your stimulation. Now, after a few days, which is 4 or 5 days approximately, when these follicles are 10 millimeters, you have 50% FSH receptors and 50% LH receptors. Now, the moment you are at 15 millimeters, it's not a very big size follicle, 15 millimeters. That follicle has almost no FSH receptors. But this is exactly the time where we are bombarding the follicles with FSH. But at that time, that follicle has almost no FSH receptors. It's full with LH receptors. Why? Because it's becoming ready for the final oocyte maturation. That's what's happening. So correct stimulation would look differently. But this is what we do, And this is the number of LH receptors, FSH receptors, LH receptors. And you see clearly this is what's happening. And this is the way a correct stimulation should look like. Starting dose, individualized starting dose, and dose adaptation on a correct timing based on the patient's response. And we have published many papers about this issue. And we look to premature progesterone rise if you don't do the step down. And I guess what is happening, you see, if you do the step down and you measure based on FSH value, you see the higher is your FSH, the higher will be your progesterone. You see here, if you have high FSH, your progesterone is higher. But on day 8, for example, if you go down, you have less FSH, your progesterone is suddenly higher. So the progesterone which is being produced is directly linked to the amount of FSH which is being administered. Now, you might say, yeah, I give 200, I give 250 or 300. Again, I would put a question mark behind it. Imagine you give 200 to Mrs. X, and you give 200 to Mrs. Y. These two ladies, one of them lives in Hanoi, the other one lives in Ho Chi Minh City, but they have the same demographics. They take the injection at exactly the same time, 8 p.m. They take on day 5 or day 6 at 8 a.m. the antagonist. And at 10 a.m., you measure the systemic FSH. So they have taken exactly the same medication. Do you think they will have the same systemic FSH level? No. And this is exactly that paper we published a few months ago. So we looked to different systemic FSH levels at exactly the same time administered, with the same demographics. There is a lady, she has an FSH of 7. There is a lady, she has an FSH of 27. So dose is not really important. Important is how much of that FSH is present, because this is linked to the metabolism of that lady. This is linked to the clearance, glomerular filtration of the kidney. This is what is important. And that is why we published this paper also a few months ago, I think 6-7 months ago, with Barbara Lawrence, where we said, look, guys, maybe we should start measuring the FSH that we administer. Because if you use your recombinant FSH at a certain dose, you have a perfect growth of the follicles, but at some point, you need to adjust and you need to respect the basic physiology of that patient. And this is another paper we presented at ESHRE this year. If you give too much FSH uncontrolled, you also create more aneuploidy. Now, unfortunately, there have been studies comparing different drugs with one individualized and other non-individualized pattern. Now, first of all, I don't think this is a way you should do a study. You should not individualize one group and non-individualize the other group. Here, for example, comparing folitropin delta versus folitropin beta. And at the end, you see non-inferiority in terms of oocyte retrieved, ongoing pregnancy, implantation, live birth was demonstrated. But I think as a scientist, you cannot have one individualized and the other group non-individualized, because you bring one group into disadvantage. Furthermore, you need to do dose adaptation in order to respect the basic physiology, in order to prevent premature progesterone rise. Because if you don't do that, what will happen? Your endometrium will become less receptive. If you look, for example, the limitations of the so-called ESTE trial, the starting dose in one group was individualized, the other group was fixed dose, whatever happens, fixed dose. But you might have patients who are undertreated, or you might have patients who are overtreated. And furthermore, if you give that dose, the dose reduction might happen because they were afraid of hyperstimulation. But as I told you, hyperstimulation is not what we are worried about. We are worried about quality of oocytes and quality of the endometrium. And if you don't do these dose adaptation, it will jeopardize. And I think it's unethical to do it that way. Many studies have looked to individualization, and we know that with individualization, you always harvest better outcome than what you are looking for. After this study, 2 more studies came, especially in Asian population, where they did exactly the same. They repeated the same, and at the end, the result was similar. It was an Asian population. However, I think the so-called grape and stork trial, if you put them together, you will see that the starting dose, again, in one group was individualized, the other group was non-individualized. And a lot of young women, which are good responders usually, and you see they had, of course, higher progesterone rise. Now imagine if you have high progesterone rise because it's not individualized, it's uncontrolled, it just push it and go for it, of course you jeopardize the quality of the endometrium, and possibly you might even jeopardize the quality of oocytes. So I think it's really unethical. And honestly, I don't know how one can accept and publish these kind of papers. And if you take a look, the same comment was present in the stork trial and also in the grape. And you see, why did I speak about progesterone? Because the progesterone was elevated in one group, because it was uncontrolled, it was not individualized, and maybe they didn't have the knowledge to individualize towards the end of the follicular phase. It's not one size fits all. And I think, I'm sorry, but biologically, it is not correct to rely on stimulation based on a variable which varies significantly, which is the AMH. I think in the era of individualization, we need to have a better understanding that we have multiple variables we have to look at, the protocol we are looking at, but you see, it's not only the initiation dose that we have to look at. It's also dose adaptation in order to respect the basic physiology, meaning step down, because a follicle of 50 millimeters onwards has almost no FSH receptors. So to conclude, ovarian stimulation changes not only the endocrine environment, it changes the endometrial environment. Progesterone is an important hormone. Progestation is a hormone for pregnancy, but it should not be there in the follicular phase. And it should not go up as rapidly as it goes after the trigger shot, and this is directly linked to the way we stimulate. Era of individualized medicine, and this is the topic of the meeting today, two things. Initiation dose needs to be individualized, and dose adaptation during stimulation, and step down towards the end of follicular phase. The key message is one size does not fit all. Caution, step down. Thank you very much for your attention.